Hey, welcome everyone. Thanks for joining us. We have an exciting discussion lined up today to explore mental health care in India through the lens of the COVID pandemic. We have a great group of panelists with varied and diverse experiences and perspectives, so I think this will be a wonderful discussion. I'd like to start off by extending a happy Dasara, and Durga Puja to those that are celebrating. And introduce the format of the panel. So we'll begin with brief opening remarks and introductions from the panelists. Dr. Cruz and I will move into a guided discussion with questions to explore mental health care and explore what's happening on the ground in India currently and the exciting innovations and situation that we find ourselves in. During that, feel free to place any questions that you have into the chat box at the end, time permitting. We'll take as many questions as we are able to. So with that, I'll turn it over to Dr. Christina Cruz.
Hi, everyone. Thanks for joining us today. We'll start with an introductory remark from Dr. Christy Page, who's our Executive Dean of the UNC School of Medicine. She's also the William B. Aycock Distinguished Professor in the Department of Family Medicine, where she previously served as chair. Throughout her career, she has focused on access and care for underserved and vulnerable populations. She led the creation and launch of the original Family Medicine Rural and Underserved track in partnership with Piedmont Health Services. And she developed a second underserved track in conjunction with a level 1 maternity care center at Chatham Hospital, a critical access hospital. She also created the first Scholars Program, a UNC School of Medicine initiative designed to accelerate and enhance the training of physicians to benefit North Carolina's underserved populations. In addition to her work with the underserved, Dr. Page is focused on advancing the research and education missions of the UNC School of Medicine, fostering a diverse, equitable, and inclusive culture, and promoting faculty and staff wellness. Dr. Page, thank you for providing opening remarks for our panel discussion today.
Sure, thank you, Christina, and good morning, everyone. I am delighted to be with you today, and I just am grateful that you've had me this morning just to share a few thoughts as you move into discussion with our panelists today. As Christina said, I've spent my career as a family physician, and I loved the opportunity to care for patients over so many years, often seeing multiple generations of the same family, from delivering babies and pediatric care to caring for older adults. And we see in family medicine primary care pre-COVID that about 20%, it's more than that, but more than 20% of our visits include some component of mental health services. So it's a very common part of practice to care for the whole person, including their mental, spiritual, and overall well-being. As Christina also mentioned in her kind introduction, I am also focused on expanding access to high quality care for underserved populations, vulnerable populations, and rural areas in our state. And as part of my training and learning in medicine, I look back on a time I spent in India early in my career, where I had the opportunity to work alongside an Ayurvedic medicine doctor and with a healer. And that experience was influential for me as I was thinking about medicine from a much broader context. And I share that story or that experience with great humility, because I do not have the global expertise with the people on the panel today, but I do share that commitment to ensuring that everyone has the absolute highest quality of care and care that takes care of the whole person, including mental health. And so, of course, we will learn more today, but that those pre-COVID figures around challenges of mental health in primary care and have certainly been exacerbated, and we know that those numbers are climbing much, much higher and affecting so many people. The virus itself has made it clear how closely connected we all are, and so the stresses that we see here in Chapel Hill, worries about our health and our families, concerns for our children and our futures, worries for our elders and our parents and grandparents, And then all the stress about politics and the economy, racial injustice, and so many other issues. These are felt across the globe, and of course in India as well. So as the pandemic continues around the world, it's important that we support each other's mental well-being as much as each other's physical health. UNC is proud to partner with you to dig deep, to come together, and to find creative solutions to this issue here in North Carolina, in India, and all across our world. So thanks for letting me be here with you and giving me a few minutes. I'd like to turn it over to the co-moderators of our panel, Dr. Christina Cruz, who you met, Assistant Professor of Psychiatry here at the UNC School of Medicine, and Dr. Michael Materga, CEO of Broadleaf Health and Education Alliance.
Fantastic. Thank you, Dr. Page. I'm going to guide us in self-introductions from the panelists. So if the panelists, if you can briefly introduce yourself, I will just call out and in order. So Dr. Vikram Patel, would you begin?
Hi, my name is Vikram Patel. I'm a psychiatrist. I'm the Pershing Square Professor of Global Health and a Wellcome Trust Principal Research Fellow at Harvard Medical School. But I've worked for pretty much most of my career for the last 2.5 decades in India, primarily with a community-based implementation science organization called Sangat, which works very closely with state governments in India in implementing various mental health programs.
Thank you very much. Priscilla Giri.
Hi everyone, I am Priscilla Giri. I am a research administrator of a research program for Tea Leaf Mansik Swasta in Darjeeling, India. And I have been working with schools
in rural communities
in Darjeeling for the past 8 years. And also have been working on child mental health programs
for 5 years.
So I have basically been involved in designing
and implementing training programs for teachers in schools.
Thank you.
Thank you.
Thank you, Priscilla. Dr. Aparna Joshi.
Mike, I'm Aparna and I'm a psychologist and a psychotherapist by training, and currently I'm working as an assistant professor with Indian university called Tata Institute of Social Sciences. Apart from teaching and research work that I do, I've been involved in the larger field of community mental health over past 25 years, and currently I'm running one of the leading national level technology assisted psychosocial counseling project called iCall in TISS in India. And I also run another field action project of TISS, which offers psychosocial counseling services to litigants who come to legal structures for addressing conflicts in their marriages or relationships or family.
Thank you. And last but not least, Raj Mariwala.
Hi, everyone. So I'm Raj, the director of Mariwala Health Initiative, and MHI is a funding and advocacy agency working only on mental health with a particular focus on making mental health accessible to marginalized persons and communities. And we advocate for an intersectional perspective on mental health and do both capacity building along with projects that are linked to grassroots and are community based.
Fantastic. What a group of panelists. Okay, I'll turn it over to you, Christina.
Just wanted to thank Dr. Page again. I know you aren't able to stay for the whole thing, but thank you for being with us. We look forward to continuing to talk with you about this at another time. I'd also like to, before jumping in, saying thanks to the Modern Indian Studies Initiative for hosting us with this webinar and helping us think about India and its mental health during both before and during the pandemic and what's to come next, as we'll all see. So now I'll jump into the questions, and I'd like to start actually with Dr. Patel. given what you talked about, Dr. Patel, with your 2.5+ decades of experience, we'd love to hear from you what you think the state of mental health and care has been in India. How has the pandemic kind of brought things to light, worsened things if possible, and what do you see going forward given the pandemic?
That's a very big sort of scope of things, Christina. I'm going to try and be very brief. So one of the things I want to also just reflect on is my own evolution in this field from someone who is very heavily trained in a biomedical tradition of psychiatry, as all psychiatrists are, which historically has always used the binary diagnosis-focused approach to define mental disorders. I believe now, after many decades of working, that not only is this approach not fit for purpose in any sense in terms of community-based attitudes and experiences of mental ill health, but also, in fact, it's not based on any foundation of neuroscience. So it's a bit of an interesting point that we should keep in mind, that almost all the literature that we have is using an approach that actually has very limited either cultural or scientific validity. But we're limited with that because that literature is what has really guided the field for the last 3 or 4 decades. I think the most comprehensive study of mental health care, mental health needs in India was the National Mental Health Survey that was sponsored by the government's Ministry of Health and Family Welfare. It was 2 or 3 years ago. It's the largest study ever conducted in India, so it's best for me to just reference the findings of that study rather than individual pieces. 33,000 adults surveyed using, again, these very biomedical, but nevertheless that's the evidence we have, diagnostic instruments, and reporting that about 1 in 10 adults had one or another form of a mental disorder as classified in the World Health Organization's ICD. That translates into roughly, and I would expect it's the same with kids, I would expect, therefore, that translates into about 100 million plus people in India at any given point in time who would actually meet diagnostic criteria of a mental disorder. So that's a vast number, and it's something to keep in mind. That doesn't mean all these people need treatment, by the way. But so we should not be conflating the meeting of diagnostic criteria as meaning automatically that requires psychiatric care. Another really important metric is that of suicide mortality. Now that's a much harder metric because dying is a binary outcome, and there can be no question about the validity of that particular metric. When you look at that metric, I think actually there are very worrying signals from India. India now is the home of 1 out of every 3 female suicide deaths in the world and 1 out of every 4 male suicide deaths in the world. But India only actually contributes about 10% of the world's population. So you can immediately see a very disproportionate burden of suicide, particularly for women. And also in the case of the life course, particularly young Indians, much of the conversation on suicide in India is focused on farmers. Actually, the real epicenter of suicide is not in farmers, but it's actually in young Indians who are trying to make a life for themselves. And I want to finish then by the other question you asked me, which is about what has the pandemic uncovered? I think the pandemic's uncovered many different things. Most importantly, the disconnect between the stated reality of solidarity between different peoples in India and the way actually different peoples have completely worked to cross purposes. So for example, the reaction of different classes in India to the government's policies really reflects actually how disjointed how fragmented India's society has become. I speak very specifically from the position of the wealthy in India who celebrated the lockdown that happened in India, completely oblivious to the fact that about 80 or 90% of India's people went hungry the very next day. And I think this actually exposed in my mind something that's always been there, but we have very nicely glossed over the last decade and a half, 2 decades, or maybe 7 decades really since independence, but it's brought into sharp relief the fragmented nature of Indian society. And if I think about mental health and how that connects with mental health, I think clearly a fragmented society, and we can see that in the US as well right now, a fragmented, polarized society is one that is not good for anyone's mental health, whether you're wealthy or poor.
Is there a way forward you see with that, given the fracture? That seems like old part of history, not that it can't be overcome, but just an incredible problem to try to unite folks across spectra and classes. Is there something you're thinking about that could start the conversation or get us moving?
Well, I think there's two levels that we can talk about. There are two kinds of power imbalances. The first is, if we consider the first part of your question, the last question, which is about mental health problems, the power imbalance between biomedical ways of thinking and community ways of thinking about mental health. And I think India has been probably one of the most innovative crucibles to try and address this particular imbalance. The fact that India has the largest community health worker program on the planet is a reflection of that. Not only is it a reflection of the enormous science behind that, but also the embracing of these ideas by policymakers. So one has to celebrate that, that India has a very forward-looking health policy that has actively embraced the idea, at least, of community health workers and providing care through primary health centers, and the demedicalization of many of these pressing health problems. That hasn't fully translated yet into mental health because mental health, the science is much newer, but it is happening. It is definitely happening, and that is something I hold a lot of promise to. The second kind of power imbalance is between the wealthy and the not wealthy, unfortunately, this is outside my realm of expertise. This is the realm of social scientists, political scientists, and maybe others on the panel might want to say something about this. But India has had structural hierarchies that go back millennia. This is not new. Of course, caste being the most obvious example of that. But I think in the last few decades, we've seen new kinds of layers of structural hierarchies, wealth being one, class being a very important one, and now, of course, religion, which is the latest one to be added in a very dominant way. So I think how you address this is one of the biggest human questions of our time. I would rank it with climate change. It's way beyond a narrow conversation on mental health. It affects everyone. It affects everything. It affects the very fabric of the societies that we live in. And I think each and every one of us, irrespective of our disciplines, as simply a citizen, needs to be involved with actually repairing these broken societies.
Thank you, Dr. Patel. I think it brings up for me thinking about Raj and the work that you're doing in terms of having to be incredibly broad and creative with how you decide to start to interact, because it's such a big thing and it can be reached in so many ways. I am wondering, I know Mike has been thinking about it. Maybe Mike, you can jump in about how do we think about how broad this is and how to start to grassroots go for a solution.
Are you asking Mike? Yeah.
I think that's a really interesting question. I think let's pose that to Priscilla. Priscilla, we're speaking about these large factors: religion, caste, and a global pandemic. And you're working on the ground in individual communities in rural Darjeeling. What are you seeing? How are they responding to mental health needs during this time of pandemic?
Sure. I would like to specifically talk about child mental health needs during these lockdown period. Because there has been a big shift after the closure of schools for these children, especially as they were in a structured setting in a school, and now they are in their home environment. So this big change has led to a lot of difficulties among some students. I would say that individual students have kind of taken up or reacted in different ways during these period of the lockdown. But like some students have experienced difficulties during this period as well. For example, in our communities in Darjeeling, a lot of children have experienced challenges because of online education, mainly because of limited smartphones among families in our communities, and also no access or very limited access to internet. So not just students or children, even 30% of our teachers who we work with doesn't use a smartphone. So this mode of education has been a challenge for our communities. Um, like, for example, the closure of schools has also led to limited teacher student interaction, as well as playtime or interactions among their peers. Um, so, as we can see, in some communities, there has been an increase or that an improvement among a parent-teacher relationship as they are spending more time with each other. But in tea plantation areas in Darjeeling, their parents are still continuing to work or go for work in the tea plantations, and these little children are spending their times with their grandparents or relatives or neighbors. So so the, all of these are always impacting the child at their home. So these are some of the challenges, I would say.
That's really interesting how different communities are feeling this stress differently. Tea plantations versus rural communities. Um, you spoke to the stress that children are facing. How does that play out? Are you seeing that play out behaviorally or from a mental health lens?
I would say that the lockdown has led to increased level of anxiety or stress among all, including children. And these could be expressed through aggression or through tantrums among the young children. Um, I would also like to add on to this that the communities that are or facing the challenges that I mentioned above are also trying to kind of overcome these challenges by themselves. Um, the teachers and parents in the communities have built a system in by themselves by so that they can continue their child's education. Like, for example, um, some of the teachers have taken up a specific area in a community where they prepare lessons and homeworks for a set of students, and the parents take up the role in um, taking the homeworks back to their homes and bringing back the completed homeworks to the teachers, so that there isn't any disturbance or discontinuity among their children.
It's really interesting to hear about the ingenuity and the innovation at a community level as they face a situation that, this is the first global pandemic that most of us have experienced in our lifetime. How about you and your team? How as a team focused on child mental health through school-based and teacher-based delivery, how have you responded?
Yes, so we as well have tried, our team has tried to work through or manage during these difficult times. Like, for example, like, I would like to first tell you about the tea leaf training program that we are undertaking in the Darjeeling Hills. So this is a training program, um, and which Dr. Vikram Patel had mentioned about the task shifting model. Um, and this is a practical application of the task shifting model, where communities, community teachers participate in a training program, a child mental health training program, and they go back to the schools, apply these techniques, and try to support children in their communities. So during this COVID lockdown, like, we have been facing difficulties because uh, our focus has always been a specific set of teachers. But we felt that during the closure of schools, the children are not in the school, but at their homes with their parents and caregivers. So we are also looking at shifting our focus not just to a singular teacher, but to the whole community. So we are trying to design programs or design messages which gets delivered to the whole community, including children.
Thank you, Priscilla. Really appreciate that.
I think it's interesting Priscilla's talked about this shift that's had to happen during the pandemic. It seems that um, although, as Dr. Patel said, there had been issues all along, this kind of really brings to light everything that's happening. I'm wondering, Dr. Joshi, how you see technology possibly as a role in mental health care, especially during the shift. I know we've talked about there will be many who don't have tech. For those who do, though, it seems like a possibility for us to be able to reach more folks, given, for example, lockdown, where you're unable to walk around or do anything other outside of your house.
Yeah, I think technology has played a huge role in addressing mental health issues during the pandemic in India. But I think before that, I would like to set a little bit of a context in which technology had to sort of, barge in literally. The first thing is, I think up till now, as Dr. Patel has already talked about, almost the latest National Mental Health Survey talks about 150 million people in India who are diagnosed with mental illness. And yet mental health, despite these huge numbers in your face, mental health was considered in India as not an issue that pertains to everyone. It was somewhere, allotted to a small subsection of the society. I think the pandemic brought the widespread nature of mental health. It became everyone's issue. So I think technology had to pitch in this context. Number two, I think while COVID has been a global equalizer across the entire globe, in India as well, I think it also brought some of the pre-existing social fissures in Indian fabric also. So while everybody in India was impacted by the pandemic, there were a few who were even further adversely impacted. And I'm saying this on the basis of the helpline data, the helpline experiences. We have initiated 2 more helplines because the demand of mental health services was so huge, and what was available was the pill therapy or nothing, right? The biomedical approach largely. So I think these vulnerable populations also had to be kept in mind. For example, these are daily wage earners, these are migrants, these are elderly, these are women survivors of child sexual abuse, these are LGBTQIA individuals, or many more. And the demand for mental health services suddenly rose. The lockdown was so sudden without any warning that people didn't have time to prepare or to cope with not only the pandemic and anxieties emanating from that, but also from the lockdown and everything that followed thereafter. So obviously, I think people were stuck in their homes, and people were feeling absolutely cut out and isolated. So I think technology played a threefold role is what I would say. The first role is to do with definitely, I think, reaching out to people, service provision, and ending their isolation, right? It could be connecting to each other, not necessarily to experts or service providers, but just connecting to each other and having the semblance of some kind of a social interaction which was missing in this whole pandemic amidst an environment which was clouded by anxiety. The second role I see technology played was in terms of information dissemination, because it was not just information about pandemic, it was information about government guidelines, mobility, transportation, relief measures. Overnight, people had to leave their homes, people had to forego their jobs. And you must have seen many people who are attending this sort of webinar might have seen there were hordes of Indians who were moving from metro cities to their villages in search of some sort of a survival, honestly speaking. So people needed information about all of this. And maybe the third thing that I can see that technology has definitely helped is, while the communities were transitioning, even mental health practitioners were also transitioning, because mental health practice in India has been offline, has been face-to-face. Maybe technology was just entering, but this entire departure from an offline mode was very, very challenging for the mental health community also. So I think technology definitely had to sort of pitch into this kind of a context, and I think it has proved to be a huge rescuer, particularly within the mental health scenario in India.
It seems to what it's getting at, what you're talking about is the connection. I mean, there's the information piece, but it's the being able to connect with either folks who can help with care or simply a connection in general, like a relationship. I'm wondering how you see the pandemic having affected relationships, and whether technology's helped, or have there been other ways in which it's not been as helpful?
Right, right. So the information, first of all, that you were talking about, I think one very important aspect of the pandemic, before I answer the relationship question, is the connection between the individual and the social lives, right? Still, I mean, mental health has traditionally situated the onus as well as the solution within the individual. And I think this pandemic very clearly brought out the connection between what is happening within the individual, or what is happening intrapsychically, and what is happening socially, be it caste, religion, class, or sexuality, or disability, or age, or several other identities. So people required not only information about the pandemic or emotional support, people also required information about resources, because people were feeling absolutely powerless and helpless. And they wanted control over the determinants of their mental health, be it employment, be it livelihood, be it health services, all of that. So I think that is one important piece to remember, that the psychosocial nature of mental health got very, very, sort of visibilized. And in terms of relationships, obviously, I think there were two kinds of trends. Indian culture is known to be largely collectivistic. And yet you can find that this very collectivistic and being locked down during the pandemic created increase in relational conflicts and huge numbers of violence also increasing, as cited by some of the leading bodies such as National Commission for Women in India. And there were other sets of people who were feeling isolated because they were stranded in some different parts of the cities and couldn't come home. So I think technology was one thread which sort of connected them together. And through the two projects that I have run, I call, which is the helpline, I think we helped people provide that kind of a space to talk about this isolation, to talk about the stress, and to talk about the social injustice that they were experiencing too. Also, I think for people who were feeling suffocated by too much of a relational sort of a, sort of enfolding, they needed also space. For example, women, it was pretty gendered a reality also, and the lockdown was not same for everyone. So people needed breathers also away from this family, and they wanted space to talk about uh, sometimes conflict, sometimes abuse, sometimes a sense of complete entrapment that they experienced also. And I think we also ran a lot of support groups for people through technology, and that was a wonderful experience to bring people from disparate states on one platform and provide that kind of support.
Thank you, Dr. Joshi. It seems like technology, at least for those who've had access, has really been quite the tool to survive during the pandemic. I know Mike's been thinking about the context and how, with technology, with different communities, how one might be having to attack this problem from multiple levels.
Yeah, I'd like to hear, Raj, would you like to speak to that as someone that has convened and sits at the intersection of a network of multiple organizations? What opportunities do you see, technology-based or non-technology-based, to broaden access to support and care?
All right, so as Aparna and others have said, there is a digital divide, but what we've learned through working on COVID is we don't need fancy tech. Often enough, a phone or access to a phone, even limited access to a phone, can be helpful. But of course, if you look at mental health and social determinants, there's a lot that tech can't do. And I'm going to set some context that in India, we saw how the virus is disproportionately affecting migrant workers, people who are part of the informal economy, the poor, the people who don't have privilege of working from home, and who were shamed for not distancing themselves anyways. Part of this was then discrimination against Muslim communities, persons from Northeast India, trans persons, people from Dalit, Bahujan, Adivasi communities. Yet these narratives remained completely invisible to the larger populace, and in fact to mainstream mental health, which is not new. But any which way, so it's not just about tech, or the barriers are not just about enabling the access, but really, and especially during COVID, about countering systemic barriers and structural inequalities. And so there were some ways in which we thought about doing that. If we have time later, I can get into that, but yeah.
I think we have time now if you'd like to speak to it.
Sure. So at this point, like I said, many people were talking, and mainstream mental health and experts were talking about how this is great, and many more people are talking about mental health. And yet, actually, for us, with a focus on marginalized communities and persons, we saw that, in fact, stigma and violence and discrimination were really at an all-time high. And in light of COVID, how do you kind of counter systemic inequalities like this, especially when mainstream mental health is not really thinking about this? And so what we did at MHI, because we're a funding and advocacy organization, was we identified various groups that were most impacted by lockdown and that have historically not had access to public distribution systems or ration shops, because social determinants were as important at that time and still are. So for example, just to give you an illustration, we identified sex workers, trans persons, persons with disabilities, HIV positive persons, homeless persons, people incarcerated in both mental hospitals and jails, Dalit, Bahujan, Adivasi communities, and Muslim communities, as well as geographically inaccessible communities. Now, all of these communities were not only kind of absent from mainstream mental health discourse, but also many are not able to access identification proofs that would enable them to access benefits as announced by governments or even by mainstream CSR philanthropy, because you require address proofs. So what we did was we funded 30 grassroots or community-based organizations, collectives and networks across the country, actually across 17 states. And we asked what they needed funding for, and a lot of it went for the social determinants. So food, rent, transportation, and that's a choice that we made as a mental health organization, that we must provide these alongside the mental health support. Now, in the organizations that we outlined or honed in on, of the 30, 23 had never worked on mental health before. So while providing material relief, we also looked at what mental health support they required, and we trained them on both psychological first aid as well as seminars on burnout. So we went the other way around, because we had to kind of look past the digital, look past tech, and obviously reach communities that we wouldn't be able to reach unless one was immersed in the community. The other thing that we did was we mobilized youth volunteers from these collectives and trained them for 4 months on psychological aids. And so they're out and about right now. So we went the other kind of way, not looking at even our traditional mental health partners who were doing work at that time already. But we went kind of the other way around to support marginalized communities at this time and get past that digital divide.
It's really interesting to hear. Your approach as a funder has been evolving with an evolving pandemic situation. Do you see that? How do you see that continuing into the future? How will that shape Mariwala Health Initiative as a funding agency going forward in a post-pandemic world?
I think at the outset, what COVID did is actually it kind of enabled us to put our money where our mouth was, to say social determinants are important. There's no point in me being able to provide counseling to a mother whose children are going hungry. Maybe she has to walk 400 kilometers to get home. There's no point until and unless I can also provide other things or figure out a way to link her to these other things. So I think that has just made our resolve stronger, along with some of the other work that maybe some of our more mainstream mental health partners did, which was to support government efforts. Say, for example, in Dharavi, which is one of the largest slum communities in Asia, one of our partners worked with the municipality to communicate within the slum, because they had very good communication networks within that area, undertaking advocacy that ration shops would be open, food supplies would be provided, or, for example, taking over running of night shelters or increasing capacity in homeless shelters. So I think that part was also critical, and it was important for the state governments that did look at mental health to actually provide that sort of support, which up to now has sorely been missing from the central government and health ministry, especially on COVID. And so the hope is, of course, that we do push the central ministry some more, especially on policy measures and implementing all the fine policies that Dr. Patel was talking about.
Thank you very much, Raj. We've heard a lot about the dynamic innovation and ingenuity in response to COVID. But even pre-COVID, India has been a hotbed of innovation around access to mental health care. And so I wanted to turn it back to you, Dr. Patel. Could you speak to some of the innovation that preceded COVID and what that means during the current situation and even going forward?
So I think perhaps the most singular innovation that has come from India has been the reimagination of who is a healthcare provider. Remember that the biomedical system really privileges people who have gone through medical education, nursing education, some kind of higher university education, but usually there's also hierarchies there as well, with doctors really being at the top. And that is the dominant system of medicine. Even India's traditional systems of medicine actually completely ape that. They have all the trappings of biomedicine with medical schools, professors, deans. It's exactly the same hierarchical establishment, except that it's under the umbrella of Ayurveda or some other system of medicine. So I think India's real ingenuity has been, and by the way, I have to say this comes from NGOs. That's actually India's greatest asset. It's civil society organizations. They're the ones that take risks. They're the ones that reach the unreached. They're the ones who work. Oftentimes, they're the only ones who actually provide any form of services, whether it's education, nutrition, or healthcare, to the most vulnerable and marginalized people of India. So let's, for a start, actually point out that in India, unlike many other countries, civil society actually picks up the pieces that are left behind by the state. And similarly, in innovation, it has always been civil society that has led, never the formal government medical school sector. But what's been really interesting is that this use of community health workers, which is this innovation that I'm speaking to, and which is at least 50 years old. It goes back. In fact, my own inspiration came from a book that I remember reading in the late 80s, called People's Health in People's Hands. It was produced by. It was edited by a man called Dr. Antia, who was actually a plastic surgeon. You never imagine a plastic surgeon. What possibly could a plastic surgeon mean when he talks about people's health in people's hands? But of course, he was a plastic surgeon, unlike those who spend all their time doing cosmetic surgery. He was doing surgery for people with leprosy, who had enormous deformities due to their leprous disease. And what he was able to really highlight was it wasn't the surgery which was important, but the engagement and empowerment of people with leprosy to promote their inclusion. That was actually the most important goal. So these are profound ideas, and they are very influential, not only to me, but actually they're profoundly influential to global health as a discipline. Let's not make any mistakes. if there are some fundamental issues around equity and justice that underline global health, they don't come from the North. They actually come from the work of civil society organizations in Africa and Asia and Latin America. And we must give credit. This is not just a local innovation. It is a global innovation. And so that's the innovation. Now, the problem really, Michael, and I'll stop here, is that these innovations don't get scaled up. That is a real problem. The health worker program has been scaled up, but it took 25 years for the first real demonstrated proof that health workers could reduce neonatal and maternal mortality, led by one of India's greatest public health icons, a couple called Rani and Abhay Bang. That work that they did in the 90s, it took 20 to 25 years before it became practiced not only in India, but in many other countries. And I don't want to wait 25 years for that to happen for mental health. And so the question really is, how can we fast track the incredible evidence we have on the use of community health workers, peer support workers, a range of other non-specialists to promote mental health and to help people recover. And that, I think, is the real challenging question facing us today.
Thanks, Dr. Mal. I do think that leads really nicely into how we think about what next. And maybe we can start with Raj. I think with talking about being an advocacy organization and funding, how would you think about moving this forward and not waiting another 25 years for the next great innovation or small innovations to be able to be part of what's happening, both access and, as you were talking about, all different ways of getting support to folks outside of just access?
So I have to agree, what Dr. Patel was talking about in terms of community-based mental health work. I think there's also, in terms of looking at demedicalization or peer work, it's actually a very critical counter narrative to the pathologization of people by, say, the edifice of psychiatry, for example. And I can take any examples, be it LGBTQIA, be it causes for, we know the examples in psychiatry. And so I would say that COVID has thrown up these fault lines in our systems and policies very clearly. And as a funding and advocacy organization, I really would want to urge other funders to say, let's join the dots. Let's look at how mental health is indeed a development issue, because it is, and we can't really isolate it from issues such as human rights, disaster response, livelihoods, public health, and indeed social justice. And in terms of the policy and implementation of work, it must be both psychosocial and really address the social and economic conditions that affect mental health. And I hear this whole productivity argument often, that you don't work on mental health and there is X or Y, Z loss in productivity. But the fact of the matter is that poor mental health is both a cause and consequence of poverty, compromised education, gender inequality, physical ill health, and violence. And so to solve that, really, there must be not just funding, because that's not the answer, but looking at funding programs that look at accessibility, not just in terms of reaching numbers or not just in terms of adding experts, but really in terms of countering systemic inequalities.
And I think that really just gets to the root, as you're saying, of what this all is. Mental health, if you will, is almost a byproduct. If it's one of the many things happening. And I'm wondering, Dr. Joshi, if you could speak to what you see as the way forward, given you've talked about the psychosocial context, given the sort of the social determinants of health that Raj has talked about. What next?
Yeah, I think while COVID has really adversely impacted communities in India or across the globe, I see a great opportunity also to foreground mental health. So within this adversity also, I see a possibility, first of all, of saying that mental health pertains to all and it needs to be highlighted, number one. Number two, I think mental health services need to be conceptualized in different ways and not just in an expert-driven way And while I provide technology assisted services, I think we all know that households may have access to technology. All members of the household don't. For example, women may not have, children may not have, young may. So I think while we are looking at technology-based solutions, we have to look at offline solutions also, because we are a very verbal kind of a culture, very offline culture. We like to meet people. So these have to be community-based initiatives. And the third way forward, definitely, I'm talk two more. One is, I think while we are looking at mental health as a public health issue, to us, it's also a developmental issue, which means it's not just the health ministry or health professionals who are going to provide solutions, but it's maybe everybody who is working on women's empowerment or poverty or unemployment issues or water. All of these people need to talk to each other to provide a fantastic environment for people to experience mental health. So services have to up their game, but at the same time, I think the creation of this kind of an environment is also very important. And the last point I want to say that while the picture is very, very grim, we are also, I mean, we have provided services to thousands of people ever since the pandemic broke through iCall and Sukoon. And we have always seen a hope and resilience in every narrative that people have talked about. So I think it's very important to not look at only problem-focused solutions, but also ways of strengthening what people have in terms of competencies, the kind of, very, very creative solutions that they have found. So I think resilience is also very important to focus while we focus on problems.
We've heard about this dominant narrative or mainstream narrative of mental health, and we've heard about a counter narrative or demedicalization of mental health and reframing and reconceptualizing. I'm interested, child mental health is a really unique space with its own set of stigmas and issues. And Priscilla, would you be able to speak to maybe how you've addressed that in your work in Darjeeling? How do you think about child mental health? What is the narrative that you use?
Sure. So as we started this developing this program 5 years back, we kind of prepared it as it was kind of a diagnostic intervention where we had certain names, such as we did use certain names to kind of individualize or to kind of identify a certain child. But as we started reworking on our programs and started reworking in developing our training programs, we kind of tried to contextualize that information into the local narrative as well. So we kind of introduced this program as a behavioral health intervention in our communities, just so that we felt it was very difficult for us to introduce the term mental health in our communities, as it was never talked about, and child mental health was something which was never spoken about in our communities. And now, like, I would say that this desire to know more about child mental health has increased so much than how it was before, especially during these lockdown periods. We see teachers who are kind of volunteering to share these messages that we have developed among their own personal groups and communities, where they feel the need or the desire to share these knowledges about child mental health among their own people. So also with the limited information about child mental health in our communities, we see and we feel that people are expressing the need to talk, and also they are more open about talking and expressing about it. Yeah, thank you.
I think that's a good segue from Priscilla to talk about perhaps the positives. And let me just pause for a second he's left, but to say thank you to Dr. Patel. He's had to leave to go to another talk. So I think that this helps us round out to considering our questions and answers And to get back to what Priscilla was saying, thinking about posing to the three of you, Raj, Dr. Joshi, and Priscilla, about perhaps some positivity. There's been certainly great challenges with COVID, as one of our audience members has asked. However, have there been any positive effects in your view on mental health, such as allowing folks to be more flexible in working, less stress around certain commutes, having more of a conversation come up about this being important? Are there things you've seen that give you some hope, as you talked about as well, Dr. Joshi, where folks are kind of latching onto something as an opportunity?
Is this a question for me or Raj?
It's up for grabs. Anyone who's wanting to. So I'd say we've moved a bit into the Q&A part, just because I think we've been able to speak to different parts, and I wanted to give the attendees a chance to be able to ask questions of you all. And to say, unfortunately, we can't get to them all, but we'll try to get to what we can.
So I'll just say a couple of positives. I think one is, I think I read one of the questions talked about less commute and more time, more productivity. And I would definitely say that there is a temporal dimension to how mental health also, was perceived, or distress was perceived within the communities. Maybe all of these things of less commute, more time at home, greater productivity were the happy or hopeful narratives in the beginning. But as the lockdown just extended week after week, we received so many calls from people saying that, well, I was hoping that now that there's so much of time, I'll be very, very productive. Very, very, I will be very happy. I'll get to spend time with family members. I'll get to catch up. And unfortunately, as I said, there is a temporal dimension. We saw that the levels of motivation did not necessarily increase as the lockdown extended, but in many, many people's lives, they decreased also. So while definitely, I think it has a temporal dimension, that it has created many more possibilities. I think another possibility which is created is grounding people into everyday life, every moment, and being more reflexive, introspective about the meaning of life, about issues that you keep pushing towards the future and never want to confront. Yeah, those are definitely positive narratives. But as I said, that it's pretty mixed. It's shades of gray, and I wouldn't definitely want to put it just as black and white. Definitely greater visibility to mental health. There have been so many narratives of people who have come forth and talked. Otherwise, it's such a stigmatized issues that they would have never ever talked about it. And I think the mental health of the vulnerable communities found a limelight or a highlight, which otherwise they would have always lived in some kind of a darkness. So these are some of the positives that I see that the time.
So thanks. I agree with everything that Aparna said, and I'll just add a couple more examples. One is, I think, that the state government of Kerala really showed how to build a mental health response to a public health emergency or a disaster. They constituted a psychological support task force that was both inter and intra-departmental. Now that included the district mental health program. So that was great. So we saw how that worked, along with Disha, which is a 24/7 telehealth helpline, which then had a team of trained professional social workers and counselors handling it. And so that gives us, all the other states as well as the central government, a good kind of blueprint to look at. And I think the second thing is, unfortunately, even before COVID hit, I believe that we were in a mental health crisis in this country. We had wide-scale protests against citizenship laws. We had riots in Delhi, all extremely fraught events, even as we went into COVID. And as those were happening, we saw lots of marginalized communities, LGBTQI community, trade workers, unions, all coming together and supporting each other, getting relief, getting medical aid, especially where riots were concerned. And we found that those groups actually continued on when COVID started and started shifting focus to relief and support. And so that for me was incredibly powerful and positive.
I think I'll take one more from the Q&A and pose it to all of you again, if that's okay, and maybe Raj first, given what you just said. One of the Q&A is asking about how the mental health issues may have been different amongst the different communities during the crisis and now, and perhaps how have they set aside their differences to come together? Has there been some mutual finding in the middle? Has there been a more understanding of the other side? Have you seen any evidence of that?
So if you hear any yowling, it is my cat. Apologies. But yes, there has been coming together and allyship due to struggles faced. And so at the beginning of the pandemic, there may have been more pressing concerns around material aid, uh, pressing concerns about maybe accessing medication. And this is especially for persons living with HIV/AIDS or TB survivors, where there was just no medication available, yet being able to reach out as collectives to different organizations, managing to organize medication. Now that all of that is getting easier to do, it's more the kind of looking ahead and how are we going to handle this now, livelihood concerns, that type of thing. And of course, the wearing down, as Aparna said, lockdown has been unending. So some of the mental health issues stay the same, but I think that due to collective action together, a lot of the maybe more material needs have or material state has been ameliorated. Yeah.
Thank you, Raj. We just had a question come in from someone joining us from Kalimpong in India, who is a teacher by profession. And she notes that mental health is a taboo topic in her region and in her community. And she's asking how can she talk about mental health of children with a parent in a way that would be acceptable and would not hurt their sentiments, or would be a way that she could participate in mental health care for the children that she works with. Priscilla, I know Darjeeling and Kalimpong are both close together and in the same region. Do you want to speak to this?
Yeah, sure, Mike. So I would say that firstly, to build a positive relationship between the parent and also among the children is something that I see as a first step in talking about mental health with parents as well as a child. So I would like say that the first step would be to make or start having conversations, but not just focus on what the alarming, as it says, it's an alarming, something that's alarming. Not just talk about that, but also try to see what the child is like doing good about, or what the child does, or what the child is, how the child is in a school or in one's or in the teacher's eyes. So maybe not just talk about the alarming behavior that the teacher sees, but also the things that the teacher, the good behavior or the positive behaviors that the teacher sees. And starting one's conversation through that would help build relation with a teacher and a parent, and then one can like talk about the behavior or the alarming behavior one is noticing with the parent. So I feel that that is one way to introduce ourselves and to talk about mental health in our schools and communities.
Thanks for that, Priscilla. I think it really highlights what perhaps everyone has been talking about underneath, which is the ability of an individual to really make a difference and take upon him or herself some piece of this. And we heard from Priscilla how a teacher can do it. We heard from Aparna how technology plays a role. We heard from Dr. Patel kind of the long view of how things have been going. And then we heard from Raj about how the collective comes together. And so I just wanted to thank you all for this discussion. I think it's really highlighted how resilience and well-being has been not easy, but flourishing in India, and the innovation and the way people have come together in ways outside of mental health to address it has been astounding. Thank you for being part of this conversation. I'll close by saying thank you to the Carolina Asia Center and UNC Global for hosting all of this, as well as the Division of Global Mental Health and Department of Psychiatry at UNC. Thanks to Hillary Chen, Whitnessa Taylor, and Vanessa Ogunobi, all folks who've helped us put this together. And then thank you to Modern Indian Studies and the director, Dr. Anusha Chari, for having us on this webinar today. And thank you all for participating and being part of this.
Thank you, Christina. Thank you, Mike. And thanks for having us here. Thanks a lot.
Thank you so much for having us. It's been a pleasure. Thank you.
Thank you.
Yeah, thanks everyone. Thank you so much.
Great conversation. I hope everyone had a thought-provoking morning and evening, and enjoy the rest of your Friday.
Take care, everybody.